was a 7-year-old boy who presented to the pediatric ENT clinic with a 3-year history. So he's had this problem for 3 years. He's got, as you can see, huge spleens, liver size. They have bone manifestations, and periodically they may even have altered cells in their peripheral bloodstream shown here. This is a Gaucher cell. So that wasn't the diagnosis this week. Now, multiple endocrine neoplasias can be divided into MEN type 1 and MEN type 2. And as you can see, MEN type 2 can also be differentiated in a 2A and a 2B type. MEN type 1 causes pituitary adenomas, Zollinger-Ellison syndrome, gastrinomas, increased insulin-producing tumors, vasoactive intestinal peptide, etc., a whole spectrum of things. Doesn't cause a lumpy tongue. Menin is a tumor suppressor gene that's mutated in MEN type 1. MEN type 2 is related to mutations in the RET proto-oncogene, and the most dangerous manifestation is probably pheochromocytoma. In MEN type 2, the patients actually resemble patients with Marfan syndrome. They have a marfanoid habitus, and they have neurofibromas commonly on the tongue and elsewhere, and causes a lumpy tongue. This is tuberous sclerosis. It involves mutations in the tuberous sclerosis complex. There are 2 genes involved here, 1 and 2, and these patients develop these hamartomas, commonly in the face, central nervous system. They get pulmonary disease, they can get renal disease, they have a whole variety of manifestations that involve this particular signaling pathway. Familial hypercholesterolemia. To have lumps of this size, you have to be homozygous. Heterozygous familial hypercholesterolemia is not that uncommon. About 1 out of every 800 to 1,000 people have that. But to be a homozygous patient and have no LDL receptors at all, that's not very common. So there are a handful of patients in Berlin that have this problem. In other parts of the world, that's not the case. I had occasion to visit Damascus 20 years ago, and homozygous familial hypercholesterolemia is a common problem there. And you can see where the xanthomas are that these patients commonly develop. Marfan syndrome involves mutation in the fibrillin gene. The most dangerous manifestation here are dissecting aortic aneurysms, but the patients also have a particular habitus, tall, slender, long fingers, pectus excavatum, and dilatation of the aorta. The first topic in the New England Journal is fairly involved. It's a complicated topic. It involves patients with chronic obstructive lung disease. We can categorize chronic obstructive lung disease in terms of diminution of forced expiratory volumes in 1 second compared to forced vital capacity in general, and the severity, if the FEV1 value is greater than 50%, it's not so bad. It's labeled relatively mild. If it's more than 50%, it's more severe. And if it's less than 50%, at any rate, you get the idea. So we have to measure FEV1 in these patients. And the more compromised they are, the more likely that they'll have an exacerbation of their disease. When these patients produce more sputum and when the sputum is yellow, then arises the clinical problem of whether or not they ought to be treated with antibiotics. And a An approach to this has been developed by a Danish physician that I show here, Dr. Anthonisen, and he indicates that if there's an increase in sputum production, if the sputum is yellow, if the patients are also short of breath, that would be an indication for antibiotics. If the sputum production is mild and the sputum's not yellow, probably antibiotics aren't necessary. And if it's sort of in between, then you can take your choice. Physicians like to prescribe antibiotics, and most of these patients get antibiotics prescribed. Now, the idea has come to mind that perhaps a marker of of increased inflammation might be helpful here. And in Germany, these patients are commonly subjected to a procalcitonin measurement. But in this particular study that I'm going to show you, the physicians measured C-reactive protein. C-reactive protein is an acute phase reagent. It's made in the liver in response to IL-6. It has this wonderful pentagon structure. And so proteins with this structure are called pentraxins. So this is a pentraxin. And this particular protein binds to pneumococci. And the assay for CRP was already developed in the 1930s. Whether or not CRP is as good as procalcitonin is a matter of debate. But in this particular study in the New England Journal, patients that had a CRP value less than 20, the recommendation was made that they should not receive antibiotics. If it was greater than 40, if CRP was greater than 40 milligrams per liter, they were prescribed antibiotics. And if it was in between, sort of a gray zone, the physicians were instructed to rely on the clinical parameters that are used for decision making. And what we can see here is that the patients were divided into two groups. One group had CRP measurements, which can be done with a device in the office that I'll show you at the end of this particular topic. And the patients that were managed according to the recommendations made by Dr. Anthonisen, depending upon how much sputum they produced, whether or not the sputum was yellow, and whether or not they were short of breath. So the patients also had diagnostic procedures done on their sputum to see if they had pathogenic infections. This is difficult. So this was sputum microbiology at baseline in a smaller sample of these patients, and the ones that had presumably a viral pathogen only are red bars, and the patients that had CRP indicators of inflammation are shown in red bars. The patients that had usual care are shown in blue bars, and the overall patient number are the gray bars, and then we can look to see whether or not a bacterial pathogen was possibly present, if it was only viral pathogens, or if a bacterial pathogen was substantially determined, as shown in this graph. And what we see here is that the CRP-guided group received less antibiotics than the usual care group, where the decision was made solely on clinical grounds. I guess that's not too surprising. But the outcome of the two groups was the same, indicating that the patients that received less antibiotics because their care was guided by a CRP measurements were clinically no worse off than the patients that received usual care that far more commonly got antibiotics. So the antibiotic usage could be reduced to anywhere between 30 to 50% with the CRP strategy. And the authors of this study suggest that perhaps determining CRP is helpful in that regard. And there's a device that physicians can purchase and conduct CRP measurements in the office on these patients. And that's shown at the bottom of this panel. The next topic in the New England Journal is prostate cancer. We had this topic last week, and this study that I'll show you in a moment is actually similar to last week's study, different agent. And you're aware that patients that have elevated prostate-specific antigen are subjected to biopsies, and then a decision is made on the basis of their Gleason score, how they're to be managed and whether or not the tumor is outside of the capsule, whether or not they have distant metastases, etc. For patients that have fairly aggressive disease, the standard care is GnRH agonist or a receptor antagonist of the androgen receptor. With these more conventional agents, that's referred to as a chemical castration. And patients that are castration resistant then receive other chemotherapies and other therapies in the hopes that their outcome would be improved. Now, there are new inhibitors of the androgen receptor that bind to the ligand binding site where testosterone binds. And interference of this binding results in the fact that this receptor, when it's internalized, does not conduct nuclear signaling, and the blockade, the endocrine directed treatment is better with these drugs than with the conventional agents that are otherwise given. Last week we looked at apalutamide, which was successful. This compound is called enzalutamide, but that's the idea. Competitive inhibition of the androgen receptor, binding to the androgen receptor, and completely blocking any signaling of the androgen receptor with this particular strategy. So these were men who were randomized to standard care, which would be the chemical castration treatment that I outlined to you earlier, compared to people that got standard care plus enzalutamide. And there are large numbers of patients in both groups here. These are obviously all men, about 70 years of age, scattered throughout the world. It was a multi-center worldwide study. Their volume of disease was in half the patients was already fairly advanced, and some patients already had distant metastases, and their Gleason scores were generally above 7. And the additional treatment that they got were LHRH agonists, and some even were subjected to bilateral orchiectomy. I don't think very many patients volunteered for that. It was less than 1%. So they had adjuvant androgen deprivation to a similar degree in both the groups. And what we see here is that the overall survival of the patients that got enzalutamide was better than standard care. These differences are not dramatic, and the number of patients needed to treat here is fairly large. PSA progression-free survival was also better in the enzalutamide group, and their clinical progression-free survival was also better than standard care by a substantial degree. These curves are similar to the study that we looked at last week. And if we look at a breakdown, this is a forest plot of various subcategories of patients. All the patients that received this treatment seem to do better than the patients that got standard care. The number of febrile events and neutropenia was fairly similar in both the groups, and fatigue was a little more common with the enzalutamide patients than in patients that received standard care. But on the whole, as you can look at the details here, this treatment seemed to be well tolerated. So enzalutamide was associated with longer overall survival and progression-free survival than standard care, similar to the study that we looked at last week. The next topic involves calcitonin, and calcitonin is a peptide hormone that is released from C cells of the thyroid gland, and it's a pretty good marker for medullary thyroid carcinoma. Otherwise, the role of calcitonin in humans, in my view, is not that clear. Any therapeutic relevance of calcitonin is also not that obvious, whereas in bony fish, for instance, calcitonin is much more important in maintaining the skeleton, and it seems to be the case in humans. Now, there is a splice variant of calcitonin that is termed the calcitonin gene-related peptide. And this is a neuropeptide that consists of 37 amino acids, and it's the most prominent vasodilator known. And that's the topic today, because this calcitonin gene-related peptide, and again, this is a splice variant of calcitonin, greatest vasodilator known, is implicated in several types of severe headache in humans, and that's the topic today. What we're talking about are hemicranial headaches, where only half the head is involved. One of these is the cluster headache, which is prominent behind the eye. So the person that has this problem, you can see that this eye looks different than that one. He's obviously in severe pain and this eye is tearing. These are cluster headaches, and patients with cluster headaches can have multiple attacks per day, lasting 15 minutes to up to 3 hours. And as you can imagine, this is a very debilitating form of headache. Then there are the much larger number of patients with migraine, which is also a hemicranial headache that is usually associated with an aura. Women are a little more commonly involved in than men. This is a common form of headache that's also causes major problems. So the first study, we look at an antibody that's directed against calcitonin gene-related peptide, and this antibody was tested in patients with episodic cluster headache. Now, these patients are not that easy to find or recruit, so the number of patients in both of the groups, placebo group or the antibody group, are relatively small, but the primary endpoint was the mean change from baseline and the weekly frequency of cluster headache attacks across weeks 1 to 3. So this is a fairly short-term study. And to be eligible to participate in this study, the patients had to have a lot of cluster headaches. So they were difficult to recruit. And the recruitment indeed was stopped early because of the low numbers of patients that were found that met the entry criteria. But what we can see here is that the cluster headaches in the patients that got the antibody against calcitonin gene-related peptide, the episodes were dropped by about 30%. And the safety analysis seemed favorable. So this treatment might offer an additional possibility for better quality of life in patients that have cluster headache. A similar study was performed in patients with migraine, and 1,500 patients were recruited for this study, so migraine is a lot more common. And this drug is not an antibody, it's a small molecule, but it's also related to the calcitonin gene-related peptide signaling pathway. This small molecule is supposed to block the receptor. So patients with migraine were randomized to this treatment or usual care for migraine. And those of you that have taken care of patients with migraine, there's an endless amount of treatments available for migraine, so that the standard care group received various different treatments. And so here are the patients. There are 500 patients in both groups. 1,000 patients were randomized, different ethnic groups. Most of these patients are female, and you can see their bothersome symptoms of photophobia and nausea and these various features that these patients half. And what we can see here is that the treatment's pretty effective. So the primary endpoint was met: freedom from pain 2 hours after the dose, freedom from other bothersome symptoms, and freedom from photophobia and phonophobia, and these various endpoints were also met. Although the use of rescue medication 24 hours after the dose of the material was not different in the groups. Whether or not this drug could be given in multiple doses, I'm not certain, but what we can see here is that freedom from pain was better in the group of patients that received this small molecule than placebo. Doesn't look like a cure, but the improvement here looks like a relative difference of perhaps 30% compared to placebo. And so this treatment might also offer something to an additional compound that can be offered to patients that have chronic migraine. Adverse events, people were concerned about changes in liver function, didn't seem to be the major problem as shown in this table. The review in the New England Journal concerns actually the work of Karl Landsteiner, who was an Austrian physician who did a number of things. First of all, he proved that polio was an infectious disease. That wasn't bad. But he was also interested in blood groups because he observed that blood from one patient tested in vitro compared to blood from another patient would commonly result in clumping. And he worked that out in detail in Europe and then later in the United States, where he moved to in the 1920s. He was at Rockefeller Institute and also worked out rhesus factors, received a Nobel Prize in 1930. He's also responsible for the notion of haptens, which are incomplete antigens, as you'll recall. And the review in the New England Journal is on hemolytic transfusion reactions. The initial description I thought was worth looking at by Jean-Baptiste Denis, who performed a transfusion of 5 to 6 ounces of calf's blood in some poor patient. I'm not quite sure why, but during the procedure, the patient complained of pain, that the vein that was being used for the transfusion became quite painful. And then he complained not only of pain in his arm, but he developed severe nosebleeds, pain over his kidneys, and he made a great glass of urine with a color as black as if it had been mixed with the soot of a chimney. Now, these kinds of acute transfusion reactions are not very common, but in general, transfusion reactions, although they're getting even from 2005 down to 2016, because of improvements in techniques, are continually getting less. They have not disappeared from clinical medicine. And acute transfusion reactions, so what initially concerned Karl Landsteiner, involves IgM antibodies, clumping of erythrocytes in the circulation, the membrane attack complex, complement activation, and vascular hemolysis. And the mechanisms are shown here. But there are also delayed hemolytic transfusion reactions that involve IgG antibodies that are much more difficult to diagnose because the reaction occurs after the transfusion is already over. So this is an important topic to review. Acute transfusion reactions, stop the transfusion, that's a good idea. Collect necessary samples, appropriate monitoring, intensive care unit, etc. And delayed transfusion reactions are a little more difficult, but algorithms how to approach these patients are given here. Then there's a problem of transplantation is now done across ABO against ABO compatibility for hemopoietic stem cell transplantation, but also kidney transplantation. And these result in problems that are treated with various approaches that are shown in the figure legend of this slide, and they can be dealt with appropriate immunosuppression. Then there's a table on categories of hemolytic transfusion reactions and immune reactions and non-immune reactions and conditions with exacerbated hemolysis after transfusion and various clinical syndromes that can result from this. And I've added some cartoons that illustrate these conditions. The application of direct Coombs testing is shown here. And what's used here is an antibody against human IgG, which tests the notion that the erythrocytes are covered with human immunoglobulin, as shown here, that results in a clumping reaction. So in summary, this is an important review that clinicians need to examine in detail so that they are aware of these complications and deal with them appropriately. This patient from last week with Ludwig's angina has severe infection with submental swelling in the floor of his mouth, resulting probably from a dental abscess. Annette Fiebler in Aachen drew my attention to the fact that Wilhelm Friedrich Ludwig described this condition already at the beginning of the 19th century, and he was a physician who participated in Napoleon's campaign to Russia in 1812, survived that, and is actually more known for his work on typhus than the description of this infection. Then in the New England Journal is this 8-week-old girl who has pertussis, or whooping cough. And if you want to hear her whoop, you can access the New England Journal and click this video that also has an audio presentation, and this young patient has pertussis. Now, why did she get pertussis? Because she was unfortunate enough to develop this infection younger than 8 weeks of age, because according to international guidelines of immunizing infants and children, the pertussis vaccine is given at age 2 months or 8 weeks, and this young child was just under that age group and had not been vaccinated against pertussis. Now, if you have some difficulty in memorizing vaccination schedules, I have included the schedule that's recommended in Germany for you here. The one in the United States is no different. Then there's a report in the New England Journal about scabies. We discussed this issue last week, and scabies is a subcutaneous infiltration of mites, and the drug of choice is ivermectin, which beats permethrin, which is the older treatment. And so these patients need to get ivermectin, or even the more modern product that we discussed last week that has a duration of action for 8 weeks, so that the eggs that have not yet hatched are also influenced by the treatment. Then the case in the New England Journal is this 31-year-old woman with vision loss. This began first in one eye. So she reports to an ophthalmologist who determines that her vision in the right eye is 20/30, which means that at a distance of 6 meters, she can interpret what a normal person can interpret at 12 meters. But the left eye is almost blind. The vision there is expressed in American syntax as 20 to 400 compared to 20 to 30 in the better eye. Examination is performed. The optic nerves are pink with normal cusps and sharp margins. The family history is basically negative. The mother had glaucoma, but no other members of the family reported visual loss. Now she's subjected to an MRI examination of the head and orbits, and it's not quite normal. The left optic nerve shows a mild hazy enhancement, whereas the right optic nerve does not. Now, ophthalmology is basically a subspecialty of neurology, and in neurology, the idea is to find out where it is. And if you know where it is, probably then you'll be able to figure out what it is. Now, an LP lumbar puncture is done. The results are shown here, and the lumbar puncture results are not very helpful. She's tested for multiple sclerosis because optic neuritis, which is not always visible on fundoscopic examination, would be in the differential diagnosis, but she had no abnormal bands. So the first idea is to figure out where it is, and we can, with the pattern of her blindness in the left eye, we can focus on the location, which has to be in the optic nerve itself. She also couldn't interpret color vision anymore either, and the response to light of the left pupil was diminished, indicating that the optic nerve on that side doesn't work properly. Then after a period of time, we can see that the optic atrophy developing here in the left eye compared to the right eye. Now, unfortunately, after a period of several months, this poor woman also develops blindness in the right eye. Then the discussant goes through optic neuropathy and infectious causes and optic neuritis, a variant of multiple sclerosis. This didn't appear to be the case. Neuromyelitis optica, this is an inflammatory disease, but we would also expect involvement of other portions of the central nervous system. And then myelin oligodendrocyte glycoprotein-mediated optic neuritis, paraneoplastic syndrome, sarcoidosis, but we're left with the possibility that this patient has Leber's hereditary optic neuropathy. And this is a mitochondrial mutation, which would be inherited from mother. But in half the patients, there is no family history, possibly also because a second hit is necessary here. This is a mitochondrial mutation. The three mutations that are the most common are given here in this report. But toxic exposure, tobacco use, alcohol, other environmental factors are probably involved in the expression of this disease. Now, there is a potential treatment to slow down this disease, and this is a coenzyme Q analog, and this patient received that, but it didn't seem to help her very much. Now, in the Lancet, the first topic again is incretins. These are glucagon-like peptide agonists, and they were first extracted from the saliva of the Gila monster, which is a fairly large lizard that's found in Arizona in the United States. Now, incretins are synthesized in the gastrointestinal tract. They stimulate insulin release, they inhibit glucagon release, they lower blood sugar, and they seem to increase beta cell survival. Incretins are inactivated by DPP4, and DPP4 inhibitors are also available. Now, we've looked at various incretins, and this one is called delaglutide. Delaglutide is given by injection, but it only has to be given once a week. And in this large randomized controlled study, there were, in the first report, we look at the cardiovascular endpoint, where the composite endpoint was non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes. And large number of patients were randomized here. Type 2 diabetics, age is about 66. There are almost 5,000 patients in both groups, so 10,000 patients were randomized here. That's a huge number of patients. And the patients also received other cardiovascular drugs and other treatments for type 2 diabetes. And we know that the other treatments are basically all worthless. Metformin helps a little bit. Sulfonylureas probably don't help. Insulin, don't know. DPP-4 inhibitors lower hemoglobin A1C a little bit. Thiazolidine diones are probably not indicated. Other glucose-lowering drugs were also included here. But what we see here is that the composite cardiovascular endpoint was better in the dulaglutide group compared to the placebo group. The difference is not dramatic, but it's statistically significant. Non-fatal myocardial infarction, no difference, but non-fatal stroke was also significantly reduced. So the primary composite endpoint was a success, and the stroke endpoint was also statistically significant. Although overall survival was no different, but then the study wasn't that long. And if we look at this forest plot of these various subgroups, whether the people had were from Europe or Latin America or et cetera, whether they had known cardiovascular disease or not yet, the length of their type 2 diabetes, et cetera, all of these items were better. And their hemoglobin A1C was reduced by about 1%, which I didn't think was that great, but at least their body weight is also reduced by several kilograms. Their systolic blood pressure was also reduced, whereas their heart rate increased slightly. And with these compounds, we're concerned about acute pancreatitis or the development of some sort of malignancy. Didn't seem to be the case. And so though that endpoint was favorable. So dulaglutide seems to be as good as liraglutide that was reported in the New England Journal, with similar results to those shown here. Now in the second paper in the Lancet, we look at the renal endpoint. A lot of patients here, and the renal endpoint was progression of macroalbuminuria, sustained decline in glomerular filtration rate, or chronic renal replacement therapy. Now this endpoint is a little more exploratory, but the renal endpoints seemed better. These graphics are not dramatic, but new macroalbuminuria was reduced. The decline in glomerular filtration rate almost didn't quite make it, and the study's probably too short to show an effect on renal replacement therapy, but also the trends of all these data were similar to what's been reported for liraglutide. And decrease in glomerular filtration rate also looked a little better in the dulaglutide group. And so take that for what it's worth, but I think the data are encouraging because it looks like we have some other compounds now to offer patients with type 2 diabetes mellitus. The next topic in the Lancet was stroke, and this is a meta-analysis of extending thrombolysis from the previous goal of administering the treatment to patients that had symptoms of stroke for under 4 hours, extending that interval to up to 9 hours. And these patients, as you know, have to be evaluated with imaging, CT or MRI. MRI allows a more flexibility in looking at the difference between potentially viable brain tissue than does CT. But 3 studies were evaluated in this particular analysis. So 213 patients received alteplase, whereas placebo was given to 200 patients. And what we look at here is the Rankin scale, and the primary endpoint was the increase in patients that have a Rankin scale value of 0, which is means that they're basically asymptomatic. And so the asymptomatic patients, there were 15% in the alteplasic group compared to only 10% in the placebo group. That's a significant difference. And what we'd like is all the Rankin business to be shifted to the right, so we minimize the number of patients that are here compared to the number of patients that are here. There is a risk to this therapy, and that's the appearance of symptomatic intracerebral hemorrhage, and that was more common in the alteplasic group than it was in the placebo group. Now, I've mentioned the automated perfusion imaging that can be determined by magnetic resonance imaging. Here's a review on that topic that you can look at if you're interested in this. These are the forest plots in patients that, in all the patients or the patients with perfusion mismatch, which would suggest that there's still viable tissue. And if we look at both of these analyses, the alteplasic group is favored in terms of the improvement in their Rankin scale. But if we look at this in a little more detail, we see that the difference in patients that have an MRS score of 0, 9% here and 19% here, which is almost a doubling of numbers of patients that had an MRS value of 0 compared to the patients that were not evaluated in terms of the perfusion mismatch score, where the difference was 10% versus 14%. So this additional imaging modality seems to suggest that it has a little more to offer than CT perfusion alone. The next topic involves polio vaccine, and this is Albert Sabin. And Albert Sabin introduced the attenuated oral polio vaccine in 1960. Now, the Salk vaccine was available already in 1956, and it was effective, although Dr. Sabin's vaccine was much better. And with the introduction of Dr. Sabin's vaccine, polio disappeared from the United States and Europe. But Sabin vaccine has some problems because the attenuation is of such a degree that some patients have problems and they can develop a polio-like syndrome after receiving this vaccine, although that's not terribly common. So in this vaccine study, the safety and immunogenicity of 2 novel live attenuated monovalent oral polio vaccines was studied in adults that had already been vaccinated against polio with the Salk-like vaccine. And these patients, these normal subjects, were then locked up and all their stool and samples was collected to see how long they shed virus and this sort of thing. So we have 2 vaccines and 2 groups of 15 volunteers that received these vaccines. Their characteristics are shown here, and serious adverse events did not occur. And we can see, we would expect their stool samples to be positive for live virus because they got live virus, and samples PCR positivity with the 2 strains is shown here for candidate vaccine number 1 and candidate vaccine number 2. So there is viral shedding of these 2 polio vaccines, although development of immunogenicity was shown for both vaccines. So the investigators were happy with that. So this looks like these are novel oral polio vaccines that seem safer than the Sabin vaccine, and obviously are more giving little children a sugar cube with the vaccine is easier than squirting them parenterally. The review in the Lancet is on adult spinal deformity, scoliosis in other words. We're not talking about childhood scoliosis. The etiology of that, to my knowledge, is still not known. This is scoliosis that develops in adults. And adults can also develop scoliosis, and they develop this basically because of degenerative conditions and back problems of various sorts. And these problems can be dramatic, as shown in this röntgenogram here. And the causes involve postural changes, alterations in muscle activity, compression of the spine, loss of disc height, problems with the facets and arthritis of posterior elements, etc. That differential is shown here, and how these patients are evaluated and what's to be done with them is outlined in various graphical displays, because they require complicated operative procedures, and those are shown here. And so I think probably vigilance equals avoidance, and so we need to avoid spinal problems in adults so that they don't have to be subjected to this business. The next topic in the Lancet involves G20. I had to look up to see what this is, but basically this involves 19 countries, and the European Union is considered to be one country. And basically the G20 countries that meet periodically to discuss economic issues and generally elicit violent protests among leftist demonstrators, they're listed here. So basically, across the planet, this is about 4 billion people in all, and these are the people that belong to so-called emerging countries, which is a euphemism for some of the people are rich, as compared to developing countries, which is a euphemism for all of the people are poor, and then the rest of the world. And the issue here is the transfer of developmental assistance for health and how the G20 countries contribute to that particular issue and how their behavior has changed in the last 20 years. So the topic of this review is the G20 and developmental assistance for health, historical trends and crucial questions to inform a new era. And what we see here is I think the G20 countries have actually done a pretty good job. This is 1990 to 2018, and they've increased their contribution to worldwide health tenfold, not so bad. So these are the G20 countries compared to non-G20 countries that obviously can't contribute very much. Then there are also private contributions. I assume these are billionaires with a guilty conscience, like Bill Gates and nice people like that. And actually, the distribution here has been fairly constant since 1990, with some blips going up and down to 2018. Now, if we look to see how much the countries give individually, that was also given in the Lancet, compared to their gross domestic product, how rich they are, these results are shown here. And some countries don't have very much, so they can't give very much. Some countries have a lot and give. Saudi Arabia, for instance, their contribution is 0.001%. They should be ashamed. They don't do any better than South Africa, which is poor, at least compared to them. The Japanese do pretty nice. So if you're interested in those issues, you can look at that. Now, the bigger the circles are here, the more problems these countries have with the loss of global burden of disease, deaths. I've forgotten what the abbreviation stands for, but basically in terms of a loss of functional life years. And so India and China have the hugest population, so they're very large. And the plot here is developmental assistance against gross national income per person in these various countries. And you can look at these maps of distributions, and actually the recipients here in Africa, I think they have major problems, but at least they're getting some attention from the G20 countries. Now, before we quit, at my age, I'm interested in sudden cardiac death. and here are some quotes here. It's not that I'm afraid to die, I just don't want to be there when it happens. That was Woody Allen. The trouble with heart disease is that the first symptom is often hard to deal with, sudden death. If your time hasn't come, not even a doctor can kill you. That's probably true. I don't want to achieve immortality through my work. I want to achieve it by not dying. Good idea. He's either dead or my watch has stopped, etc. So you can look at these, because these are the guidelines for the prevention of sudden cardiac death as published in JAMA. And basically it concerns patients that have reduced ejection fraction. And if your ejection fraction is less than 40%, there's pretty good evidence that you ought to be getting a beta blocker, a mineralocorticoid receptor blocker, an ACE inhibitor, and drugs for heart failure. And if it's less than 35%, you probably should be getting a programmed defibrillator. And if it's less than 30%, the evidence for being outfitted with the defibrillator is pretty good. And the rationale for that is shown here. Finally, in the Lancet, we see this collection of young boys here in rural Ghana, and every one of them has an umbilical hernia. We're not told whether or not they're related. I guess they might be, but at their age, they all look like they're older than 2. The size of these umbilical hernias suggests that they should probably be repaired. And this little report is on umbilical hernias are common at birth. Usually they're small, and usually they disappear by 2 years of life. But if they don't, and if you live in Ghana, you might get your picture published in the Lancet. Thank you for your attention.
Vielen Dank, Herr
Bitte.
Dankeschön.